Thank you. Welcome, everyone. And thank you for joining us today for MVC's preoperative testing work group, our actual first preoperative testing work group of 2025. My name is Emily, and I am a site engagement coordinator with MVC, and it is my pleasure to be facilitating this work group for you today. Just have a couple of housekeeping items to walk through before we get into the presentation. First, this work group session is being recorded. The recording and the slides will be shared with all of you following the work group in our post work group follow-up email. So be on the lookout for that. Second, a reminder to please double check that your mic is muted throughout the presentation so that we have a good recording of this presentation for future use. However, you are welcome to unmute and ask questions. We'll be hosting a couple of different question and answer sessions throughout this presentation, and that'll make a little bit more sense when I get to walking through the agenda. And then finally, we will also be monitoring the chat throughout the presentation, so feel free to add in questions, comments, thoughts. If there are questions, we will get to those during the designated question and answer sessions today. For those attending this work group for P4P credit, just a reminder that we look forward to your active participation throughout the work group. That's going to include responding to any polls, discussion questions, and then partaking in that question and answer portion of the work group. There will also be a post-work group survey. We always share that post-work group survey at the end of the work group in the chat, but it will also be shared in that post-work group follow-up email if you're not able to grab that from the chat today. As a reminder, in that survey, please note the hospital that you are attending on behalf of and would like your attendance credit to be credited to receive your P4P credit. Please also only complete one survey for this work group as applicable. Right, so our agenda for today's work group, I already walked through our housekeeping and our P4P credit reminders. We're going to be starting out with a presentation from Jennifer Bennett on the preoperative testing with a purpose. She's going to review some processes that were implemented at Henry Ford Warren Macomb within the MSQC appropriate preoperative screening for low-risk surgeries pilot. That presentation will be followed by a brief introduction to the Right Size Initiative by MVC's own director and Right Size co-PI Hari Nathan. So Jennifer, our wonderful presenters today, Jennifer is the lead quality and patient safety coordinator for Henry Ford Warren, Henry Ford Madison Heights, Henry Ford St. John, and Henry Ford River District Hospitals. She received her Master of Business Administration from Wayne State University, as well as a Bachelor of Science in Nursing from Wayne State University. Hari Nathan is an Associate Professor of Surgery at Michigan Medicine, a Right Size co-PI and Director of MVC. So welcome our presenters. We're going to start off with Jennifer's presentation. So I'm going to pass the baton over to her, allow her to share her slides.
Thank you, Emily, and thank you to everybody for taking the time to attend. So very excited to share. I think I might need permissions, Emily, to share the screen. I'll send a request.
Should be able to share, Jennifer.
Okay, here we go. There's a little bit of a lag, my apologies.
Okay.
Okay, and if you could just, I think we're able to see my first slide, correct?
Nope, can see it.
Okay, wonderful. Okay, well, I'm just going to share with you, as Emily had already spoke about some of the work that we've have done at our Henry Ford site, specifically Warren and Madison Heights. And this was actually part of a pilot program through the Michigan Surgery Quality Collaborative, which is one of the many wonderful CQIs of the Blue Cross Blue Shield program. And so I'll get a little bit more into that. First, we're going to start with just a group poll, just to kind of get a consensus of education on this topic of the group. So in 2017, what was the estimated cost reported for unnecessary testing and treatment costs annually nationwide, so within the United States? So we have our choices on the screen. We have for A, we have $100 billion, B, $200 billion. We have for C, it would be tw 20 billion dollars, and then we would have 200 million dollars for D. So, and I'll lean to you, Emily, when we have enough responses to continue.
You're at about 86%. So I say we move forward.
Okay. Did you, should I unveil the results? Okay.
Yeah.
All right. So we have, it looks like actually, so our answer actually is B. So, which was amazing to me too, the amount of, and this is in 2017. So we just know as time has gone on, those costs have continued to rise within our healthcare system. So it's actually the largest number. So, good lead as we kind of continue on to see what we can do within our organizations to kind of minimize those costs. And if we continue to our next slide, it's just like, what are people saying about it? It's actually like a very topic that has a lot of concern and sparked a lot of discussion. I have in here from Michigan Medicine an article that was written. Routine testing before surgery remains common despite low value, and that's something that we're really looking for within the MVC. Is just like, what is the value that we're getting from all this money that's being spent, and is it of a value for the patient even beyond the economical aspect of it? And additionally, we have, there's been journal articles written by the National Institute of Health. So lab testing overload, a comprehensive analysis of overutilization in hospital-based settings. And then also I included in here too, an article that has been written too. So it's called Blood Money. So fraud, waste, and abuse in pathology. And I've provided all of those links if that's something that you want to read further into after the presentation. But definitely a very important topic that we're discussing today. And so understanding the problem. So what is the problem? We kind of dissect that a little further. There was a science-based research company that actually over 600 physicians were polled. And so these were the questions and these are responses that they have from those providers. So physicians say unnecessary tests and procedures in healthcare system are a serious problem. Is it, according to them? So these are the responses that they have from that group. And so when asked, do you think the frequency of unnecessary tests and procedures in the healthcare system, so how frequently is it? How big of a problem is it? And if you just look down at the pie chart, you can see that very serious problem represents a third of the responses. The majority of the responses, somewhat of a serious problem at 44%. And then we have probably about a quarter of the pie saying that it's not a serious problem or not a problem at all. When the same providers were asked in your own practice, how often do patients ask for a test or procedure that you think is unnecessary? Which I found this was a very interesting one, as you know, we're all consumers in our care and within healthcare. So they're 10%, only 10% say every day somebody comes in asking to be tested for something that the provider wouldn't necessarily recommend to be in their best interest. 20% saying several times a week, and once a week for 17%. So about half of the pie that they're saying here that, you know, patients are coming in and they're asking for tests that may not bring a lot of value to their own personal health care. And I think we'll dissect that a little bit more as we kind of continue along. Physicians are talking with patients about the issue when it arises. So, are they talking to the patients when they're coming in and they're asking for these tests 50% of the time within a week, something that's deemed unnecessary? What is the response? So, same physicians being polled. How often do patients follow your advice and avoid the test or procedure? And so, very encouragingly, it says 37% always or almost always. So if they're taking the time to kind of explain and educate the patient why that test, that procedure may not necessarily be in their best benefit, it's looking like over half of the pie. If you look at 37% and often at 33%, that they're really adhering to their provider they're choosing to guide their care. So they have a very strong voice um, in what we do for our patients and within the industry, the physicians do. And then when additionally polled, it said, let's say a patient came to you convinced he or she needed a specific test, and you knew the test was unnecessary, but the patient was quite insistent. So, they were polled, just what would they do? And so over half of them actually said that they would just go ahead and order the test, but advise against it, but they would go ahead and adhere to the patient's wishes. And we have about 40% that said they actually would refuse to order the test, and then the remainder of the pie, not sure. So, and then there's additional polling. So, in your own practice, we're asking like, what is at the root of the problem? So, in your own practice, if this is a reason you sometimes end up ordering an unnecessary test or procedure, why? Why are you doing it? And so overwhelmingly, you see over half are malpractice concerns. So just the legal ramifications, the liability of it, which is definitely a talking point. And then also too, just to be safe. So um, they always have that percentage of cases where maybe somebody might be an outlier. And so just due diligence and just making sure that you're providing like the best screening that you can for the patient. And then additionally, as you go down, they want more information to reassure even themselves, patients, and just being insistent, wanting to keep patients happy, which we know customer satisfaction is something that, is of emphasis within all of our healthcare systems. Because once again, patients, they're consumers, they're our customers. And then to make them feel like they have a voice in their care, make them have the final decision. And then also too, just maybe not having enough time with the patients to have that dialogue back and forth. So just kind of the easiest way to just address it is to just, give the consumer, give the patient what they want. And then also too, as you kind of like go down the lower percentages, so fees, and then technology was a response as well too. And so then asked too, then how often does this happen? And so it's a breakdown on the right where it's saying almost always some of them responded, often, half the time. So once again, 50% of the time, this is what's happening with the ordering of unnecessary tests, why they're doing it, and how often they're doing it from this poll that was taken of these 600 providers. And so I'll open up. I have one more poll for you. And so when providers were asked what they felt would be the most effective way to reduce unnecessary tests and procedures, what did they say? So we have malpractice reform as a choice, having specific evidence-based recommendations in a format designed for patients that MDs could use for discussion, having more time with patients to discuss alternatives, and the last, changing the system of financial rewards for ordering tests and procedures. So what did they perceive to be the answer?
looks like we came to a halt at about 83% participating, Jennifer. So I think we're good.
Okay, that's okay. That's okay. We'll take that. So what was the consensus? Let's see what your thoughts were. Okay, malpractice reform, which, had a high percentage. So that's a great choice. Having specific evidence-based recommendation, always a great thing. I have a background in research, evidence-based. You always can never go wrong with that. Also, too, having more time with patients and changing the system of our financial rewards. And so the answer is, if we continue on, you can see it actually was all of them. So those were all of the responses, and this is representative in the percentages that each provider responded. The dark is vary and somewhat, but you can see high percentages across the board for those specific things. So all of those are a part of the pie, a part of the problem. And then you can see who do you think is the best position to address the problem of unnecessary tests and procedures. And you can see overwhelmingly the physicians even identified themselves because they're the ones that, primarily are the ones that are ordering them, correct? So that, and then also they pointed to government, so maybe like more of a regulatory kind of like concern. Once again, going back to malpractice with trial lawyers, patients being 3%, and then it kind of goes down from there for like the smaller percentages for what they perceive to be the solutions with addressing this issue. And so now I'd like to share the information based on the pilot project that was done by our wonderful MSQC quality coordinators at Henry Ford sites that we participated in. This occurred in 2023. And so just to kind of show you the process that we implemented at our sites, that lessons learned and just like our process in general, that we can kind of share with those that maybe are just starting to implement this with the MVC as a selected project for the 2026-2027 year, and just show you some of the lessons that we learned and some of the things that we were able to achieve. So for those that aren't familiar with the MSQC, once I said at the beginning of the that it's one of the Blue Cross Blue Shield Pay for Performance Quality Improvement Initiatives, and it's surgical based. So it's a Michigan Surgery Quality Collaborative. And the overview of it is surgeons and hospitals statewide, they collect and analyze data to improve the quality of care for patients undergoing surgery in Michigan. It's a PSO, so it's a patient safety organization that's designed by the Agency for Healthcare Research and Quality. So they're constantly reviewing and looking for our areas of opportunity for improvement for the quality of care that we provide for our surgical patients in Michigan. And the teams are basically everybody that you would expect to be involved with the surgical process. So surgeons, anesthesiologists, nurses, quality experts, surgical technologists, and administrators, all working together to see how that we can improve the overall care for our surgical patients. The goals and objectives is to identify, like we said, what's the value for the patient, even just monetarily too, for like our healthcare systems. And are we, for the money that's being spent, the utilization of it, are we getting the best outcomes for our patients? And then also too, to eradicate preventable adverse events for our events, as we sometimes call them. So infections, just any poor outcomes that we wouldn't want for any of our surgical patients. And then they disseminate, based on that, all the data that's collected, the best practices for surgical, preoperative, intraoperative, and postoperative care for these patients. And so the pilot was appropriate preoperative screening for low risk surgery. Was a pilot basically. And so looking at the data that was available, preoperative testing rates for low risk surgeries were ranging all across the board. And we see that within MVC too, anywhere from 8% to 85%. So really big range we're looking at. So the task of this project is to look at is where can we kind of like start to cut away from the unnecessary to kind of like bridge a little that broad gap in the testing that we're doing for low risk procedures in our patients that we're seeing preoperatively. And the why, once again, we already talked about not recommend it's not recommended. Like there's all types of academics that do research on this. I showed at the beginning of the presentation all kinds of research articles. National Institute of Health have done studies and reviews. And so we just know that there's always room for improvement. Associated surgical delays. So once again, just getting back to giving our patients the best care that we can and just the best utilization of their benefit and wasteful spending, eliminating that, and just the stress to the patient. Even if you just think about yourself when you're getting like your blood drawn for just a normal visit that you might have with your PCP, it's, you know, it's a stressful thing. So if we can avoid that in any way or reduce that, then everybody wins. And so with the base of this pilot, it was bringing in the information that had already been researched by Choosing Wisely, and then also the National Institute of Health and their recommendations. And so just looking at the tests that testing for patients that are undergoing like low or intermediate risk procedures and just looking at what we could eliminate, what's being overutilized. So that is pretty much the premise for the pilot that was done. And so appropriate pre-screening, screening for low risk surgeries. So once again, we already kind of touched on this. So less testing. So it's just better for the patient overall. And then also too, it helps with just like the utilization of the system and the efficiency within our surgery centers, hospitals, all of that working together. And so for this particular pilot, like I already said, it's focusing on low risk surgeries was the initial rollout of it, and just trying to eliminate just that overuse of preoperative testing in these particular surgeries that were targeted. And just looking to see like how much we could move the needle, as we talked about, just that 8% to 85% for that utilization of preoperative testing, that range. And so with the pilot, we're just going to monitor we monitored the progress that we could see when like moving that needle with targeting on these specific low risk procedures. So these were the procedures that were identified that we were going to really look at the amount of testing that's being done and what could be eliminated. So breast lumpectomy, minor hernia repairs, and laparoscopic colectomy was the 3 targeted low risk surgeries. And then these were the particular preoperative screenings that were looked at. So once again, the blood work. Does the patient need an EKG, cardiac stress testing, chest x-ray? And I think that a lot of us can identify this within healthcare. It's not always evidence-based what we do. We just may have done something 5 years ago, 10 years ago, because it's just based on the knowledge base that we had at that time. But we don't often revisit it as much as we can to say, okay, and just take a timeout as you would, right? In surgery, or take a timeout and just say, okay, why are we doing this? And what is the benefit of it? And so that's what this pilot was really looking at, based on the recommendations of the information from the academics and what they've been seeing. So as I already pointed to, so EKGs were a part of it, CBCs, echo, stress tests. So just a lot of that standard preoperative testing that we would do for our patients, even if they're having low risk surgery. And so this was the kind of going through the flow chart of how they ascertained what patients should get what and how they're classified. And so the big focus of this particular pilot is that we were looking at ASA grades of 1 or 2, were the ones that it's pretty much generally a healthy individual not really going to have a lot of comorbidities existing or other things that you would want to do additional follow-up on just to make sure that we're not missing anything before we would take them for an invasive procedure. So, as I already spoke to, these were the three different low-risk surgeries that we focused on for this particular pilot. And then you can follow the flow chart. So if it's ASA of 1 or 2, then no preoperative testing would be indicated. Or if they were ASA grade 3 or 4, then we provided additional guidance of what type of preoperative testing or clearance would be appropriate for that particular patient. And we actually went a step further to give a little bit more direction to those as we implemented the pilot and the education of them, of additional examples of what classifies an ASA 1, 2, and then 3, and additional considerations that you might kind of help guide the provider for what the patient class falls in and what the appropriate recommendation would be within this pilot. And then this is just another visual of what that would look like as far as that that flow that we're kind of applying to these patients in the pilots. And so once again, this is going to apply to patients that are ASA 3 or above. So we do know that and recognize that they would need preoperative screening, but specific to them, which ones would be the ones that truly would be indicated. And then also with this too, when the education was rolled out to the providers, their clinical judgment trumps everything. They know their patients better, but this is just a recommendation and a guide that we were trying to implement to see, once again, if we could eliminate unnecessary testing and kind of move the needle on that within our sites. And so the stakeholders for this particular intervention. So really it would just be anybody that has contact with the patient physically or even like behind the scenes, anybody involved in that surgical process, that experience for that patient. So of course the doctors, the surgeons, and then also too, preoperatively, all of the staff at the surgeon's office that would see getting them ready for surgery and even postoperatively too. So just engaging everybody, the people that would board. So boarding the surgery, what are the orders that we're going to have? So just engaging everybody that's part of that preoperative workup for the patient. And then of course our quality coordinators were the ones that are really organizing all of the stakeholders in it, just reaching out, providing the education, the why, and how it was going to be implemented at the site. So just rallying together all the troops, if you will. And then also with this particular pilot, it was collaborated with MVC, and then also to IT touches every part of patients. So just trying to get everything together and succinct to implement this for the patients. So now I'd like to go into our wins and our losses, if you will. Even the loss is a win though, because it's opportunities to learn, right? So I'll start with our wins. So the success in implementing the pilot. I will say with historically at our site, we actually had a lower utilization for the preoperative lab testing. So we started with a pretty strong baseline in this, and we were just looking with participating in the pilot, could we move the needle? How could we just improve care overall? And then also too, for what our rates would look like within MVC. And so just starting the conversation is never a bad thing. Like I said, we get complacent sometimes just doing what we do because we've always been, or we have some policy in place, but could it be like revamped? Could it be better? So that was definitely something that was an opportunity that was taken from this that we could kind of just take a look at. What are we doing and are we doing it the best that we can? And also too, just a chance to implement once again, just like that evidence-based like knowledge. So what have we learned and how can we best benefit our patients, our clients with that? And then also too, the cost effectiveness, because if we are able to utilize our resources, then they can spread more vastly across more patient populations. So that's always a win. And I would say, yeah, just basically providing just the best care that we can for our patients is always like the biggest win. And so that's something that we were able to achieve with participating in this particular pilot. And then the barriers that we occurred. So basically, the lack of communication. So just really trying to get that word out to everybody. There's so many hands that touch a patient or involved in their care, pre, intra, and then post-op, right? So just the education, the re-education, and just keeping everybody looped in. So that would be a potential barrier. I would say that we were able to implement it well, but there's always room for growing and improving and expanding that. So. And then with providers that weren't necessarily hospital employees, so those outliers, for lack of a better term. So just really engaging them and bringing them into the fold, especially if they were on not operating on the same EMR as the hospital. So that potential gap and trying to bridge that and work around that. So that was one barrier that we encountered. And then also to the feedback lag time. As we know, within the collaboratives, there's often lag times that we work in. So we're doing the work, but we're not necessarily seeing like an immediate result. Are we going in the right direction, or do we need to swing in another direction to get the benefit that we're looking for? And so I just wanted to share the data from this particular project, since I did mention that this was actually implemented in 2023. So this was a little bit ago. So this is looking at, this would be Henry Ford, Madison Heights, and Warren, if you're looking in the brown. So as you can see, the baseline was about 45%. So we were already operating pretty well within our cohort, where we were not above where the goal would be at that time that they would like us to be. So this was pre and then post implementation of our pilot. We were at 37.8. We were able to lower it to 31%. So, and this is looking at from the beginning of the implementation of the pilot and then through current data that's available within MVC. So definitely, I would say a successful pilot moved the needle in the right direction and started that conversation. And we hope to continue that as we have elected to participate in the preoperative pay for performance for the upcoming years of 26 and 27. So our next steps will be, as I mentioned, that we've selected that to continue to expand and to grow in this area. We're going to have presentation, as Emily mentioned, with Right Size. So definitely partnering with them for any additional input that they could give that we can provide our patients for better outcomes. And we've changed from Ascension to Henry Ford to be a part of the Henry Ford family as of last year. So definitely looking for re-engagement with additional stakeholders. And then we have the opportunity where we had the barrier before with our more fragmented EMR system to moving to Epic, which is a more integrated system that would bring more of our providers that may not be hospital-based into the fold. So that is what we're looking for our next steps. And if anybody has any questions at this time, I welcome them.
Thank you so much, Jennifer. That was lovely.
Thank you.
I don't see any questions in the chat. I'm double checking myself, but if anybody would like to unmute and ask Jennifer a question, that would be great. Okay, we're getting some good jobs. Great presentation. Thank you, Jennifer. Let's see.
Oh, thank you. Thank you.
Okay, so no questions yet.
I've got a question.
Thank you, Hari.
That was a great presentation. Thanks for reviewing your experience with that pilot project. So, for the benefit of others who may be trying to do what you did, what would you say if there is kind of one high yield thing that you were able to do to get people to change their behavior with respect to not ordering these tests? What would you say is like priority number one, the highest yield, biggest bang for buck change that you might make?
I've always found when implementing projects, get your early adapters on board first. Really get your cheerleader, like whoever that person would be. And then that kind of brings everybody else into the fold, perhaps. So starting with like our we do have surgeon champions for some of the CQIs that we participate in. In this particular one, our chief of surgery was engaged. And then bringing in all the key people at that point, because it's so big that sometimes you don't really know as the coordinator, like who would be the key person to go to. And I've always found a lot of success with just adhering to people's want. We're all in healthcare because we want to make a difference. We want to help too. So if you can provide that information that's evidence-based to say, this is where we're at. This is how this is the research that's showing how we can move the needle that's going to benefit the patient. Then you get your greatest buy-in with that because we're all altruistic and we really want what's best for the patient. And so it's really hard to kind of refute that, when it's presented. So definitely just know who your stakeholders is, like I said, and just get like your earliest adapter, your big cheerleader. In this case, we would want to right size. So ask for help. And then, you could kind of, as we kind of like move along within those that have chose to choose this for our MVC goal, then definitely just take all the resources available to you and just get them out and early and consistently, just the messaging over and over and over again. And just don't give up and just be patient. It takes time. It's not going to happen overnight, but you have to be consistent.
Mhm. Great. Jennifer, we did have a question come through on the chat from Catherine from Corwell. She asked any recommendations for health systems that are looking to implement these changes across multiple sites. And I know when you went over your next steps, that is kind of one of your next steps is to, expand some of what you've learned to other formerly Ascension, now Henry Ford sites. So can you speak to kind of your plans or any recommendations from a system level?
Sure, I appreciate actually the question because I don't think that I emphasized it enough in my presentation that there was collaboration with our MSQC coordinators for this particular pilot as well. So with our St. John site and then with our Macomb site. And so you can kind of like grow with what we have in common first, and then there may be variances with different sites. And so I would definitely just look to partner with whoever, whoever is what insert title at one site, then to do the same thing at the other as well too. Or I know that there's a lot of crossover with different like departmental meetings and whatnot. And so just finding those opportunities where you would have like the same stakeholders or the same person that you need to engage within that departmental meeting. So just look for those opportunities where you have that crossover and take advantage of them. Definitely use your resources available to you.
Thank you. That's helpful.
And a couple others come in here. I'm going to take two more and then we're going to move on to the right size portion of the presentation and then we'll come back for some additional questions. Kelly asked if there was one test that was over ordered more than the rest for your sites, Jennifer. I'm not sure if you pinpointed one particular test that you felt like was ordered more so than others.
No, that's a great question. I don't have that information. I would actually not to call out my cohorts though, but we may have a few on the call that were involved in the pilot. If you guys want to drop an answer in the chat or if you know of one, then I would welcome you too. So
I would just note that that information, if you are interested in looking at it, Jennifer, we can easily dive deeper into that on the MVC registry. On those multi-payer pre-op testing reports, there's a really beautiful table in there that kind of breaks it out by those three surgical conditions and then by individual kind of testing groups.
And actually, I see in the chat, CBC, to answer the question, was the most ordered from our team. They're all in agreement, so CBC.
And you know what? I think like as my background as a dietitian, we always ordered CBCs. It was like CBC plus whatever else you were going to grab. You always grabbed a CBC. So
Exactly. You can't go wrong with CBC, right? Wrong.
right, but it's
Right,
not
wrong.
always necessary.
Right.
Okay, and then the last question we'll take before I move on to Hari's presentation. Chris Steinberg is wondering, did someone go in person to educate office staff about reducing pre-op testing? How is education done to like in-office stakeholders?
Yes, we always utilize in person as much as possible. And in addition to that, we would send out information virtually and just to reiterate the messaging all throughout the pilot of the project. So yes, you just have to keep reiterating.
Yeah, so I just wanted to add, like, for when I was working on the project, because there were so many offices that were private as well as related to our health system, it was hard to go individually to each office, but I did meet by phone or email with the surgical schedulers, and they had a process where they attached to every clearance that was requested the anesthesia guidelines for what would be required based on the ASA format. So that way it was always going to the providers that were providing the clearances at that time, so they had a resource.
Thank you for that additional information, Monica. All right, we're going to transition over to Hari for a little bit more information about right size. Jennifer kind of mentioned it a couple times in her presentation, so we want to make sure we walk you through a little bit more information on right size. Okay, I'm going to go back to sharing my slides for you, Hari.
Thanks, Emily. For those who don't know me, my name's Hari Nathan. I'm one of the faculty here at University of Michigan and one of the principal investigators on this grant to test out an intervention to reduce preoperative testing. I don't think it's so important that we get into like all the nuts and bolts of the grant here. I'll try to keep this relatively high level and kind of give you all what I think is hopefully information that you can use and then tell you, some things about the grant that I think will be relevant and hopefully interesting to you. So, if I don't spend a lot of time on some of these slides, that's why. And just in the interest of time, I want to make sure we get through the relevant parts. So go ahead and go to the next slide here, Emily. So we'll go ahead and go to the next slide. Tell you a little bit about the team and the history. My co-principal investigator is one of my colleagues in surgical oncology here, Leslie Dossett. Next slide. But this is the team that actually gets the work done. And this is Dana Green, our project manager, Val Gavrila, our project manager from the MProof side, and then Jana Stewart, who's the associate program manager of MVC, who has worked a lot on this as well. Next slide. So the goal with this project is really to cut down on the amount of unindicated preoperative testing that's commonly done for elective low-risk surgery. And the idea really in a nutshell is to go from a default of order stuff on everybody to a default of don't order anything unless you have a good reason. And so, we often get the immediate pushback of, I want to use my clinical judgment, in order to decide if a patient needs a test. I don't want somebody telling me if, not to order a test. And my response to that is, yes, exactly. We want you to use your clinical judgment, right? Ordering testing on everybody isn't using your clinical judgment either, right? So the whole idea here is to use your judgment, is to take the history of the patient, is to consider their comorbidities. But the reality is that the vast majority of patients undergoing these outpatient low-risk procedures are low-risk patients. About 2/3 of them are ASA 1 and 2 class patients. And in most of those patients, there really isn't any preoperative testing that's indicated, again, unless one is looking for something very specific. I mean, a preoperative CBC is essentially useless, right? Because it doesn't tell you if the patient has a qualitative platelet disorder. That's not going to show up in a platelet count. If the patient's anemic, what are you going to do differently? You're not going to give them blood before the operation just because, right? So, in the odd case that you may find some very elevated white count or something like that, that's such an unusual circumstance that it certainly doesn't justify getting those types of tests across the board in everybody. And, we could make similar arguments for a variety of the tests that are done, such as, EKGs and BMPs, that in the vast majority of patients who are undergoing these tests, it doesn't actually add anything. And the evidence shows that it doesn't make the operation any safer. So the idea that I'm doing it just in case, I'm doing it just to be on the safe side, is just not borne out by the evidence. It doesn't actually make things any safer. And in the worst case, it sets off this cascade of testing where you get back a value that's kind of marginally abnormal. We don't really know what it means. So now what do? Of course, we get another test, right? And in the meantime, by the way, I'm sorry, Mr. So-and-so, your surgery is being delayed because we have to send you off to the cardiologist for this, or we have to send you off to the hematologist for this. And, I always like to tell the residents that if you go looking for trouble, you'll find it, right? And, what's happening in these cases is very rarely that we're uncovering some real problem that's just been missed by all of the other healthcare providers. Most of the time, the vast majority of the time, it's some spuriously altered value that sets off this whole list of other tests, creates a whole lot of anxiety for the patient, creates delays, reduces the efficiency of the system, results in unnecessary costs. And at the end of the day, guess what we end up doing? The operation that we could have just done 3 weeks ago, right? And so that's really what we're trying to get at here. Not, by certainly not, cases where there really is a reason, where there really is a concern, but it's that knee-jerk ordering of a whole panel of tests for everybody who's undergoing these particular operations. Next slide, please.
Sorry, Harry. It looks like there were some animations in here I wasn't aware of. Oh, all right.
So as you've heard, this is a collaborative project between MVC, MProve, which is a quality improvement organization based here at University of Michigan, and MSQC, which Jennifer very nicely introduced. And, suffice it to say that this began with some academic work with one of our fellows at the time. His name was Nick Berlin. His name still is Nick Berlin. And he published a nice paper in JAMA Internal Medicine showing the rates of preoperative testing. I posted some of that data in the chat in terms of his findings using statewide MVC data, which lines up exactly with what Henry Ford has found, CBCs being the most commonly ordered test. And we've done some work since that time that eventually culminated in submitting a grant to AHRQ, which fortunately we were able to get funded in order to actually conduct a randomized trial in the state of Michigan to see how can we develop a package of interventions that can help hospitals reduce this unnecessary testing? How can we then refine that to make it better? And then how can we test to see if it works? And so that's in a nutshell what the Right Size Project is about. Next slide. So as part of this, MSQC had a statewide option in their pay-for-performance program that started in 2023 and continued into 2024. There were a lot of people who signed up in 2023. There were fewer who signed up in 2024, but essentially there was a small incentive in that program for reducing your pre-op testing rates. Alongside this, but separately, MVC has added this to our menu for our pay-for-performance program. So some of you may participate in this where you will receive points on the MVC P4P scorecard, which will reward you for reducing your pre-op testing rates or by meeting a pre-specified threshold of testing. And a lot of this work is informed by some local work that's been done here at University of Michigan. So, we're not asking anyone to do anything we haven't done ourselves. And, believe me, I understand it can be frustrating and it can be hard because it was frustrating and hard when we did it here. But I think along the way, we've learned some things, and we had 3 sites who very generously agreed to participate as pilot sites for the grant. We learned a lot from their experience. And so as we keep doing this, we're getting better so that everybody who signs on from this point forward is the beneficiary of all that accumulated experience and know-how, not only from what we've done here at U of M, but admittedly, that's not always generalizable to every kind of type of hospital, right? What works at the big academic center may not work at the smaller community hospital. And so we've been very intentional in involving sites that kind of span those phenotypes so that we can kind of figure out what works in every potential setting. And, honestly, a lot of it is common and a lot of it works in every setting. It's just a matter of, how big is the scale of the messaging and how many people do you have to convince? Next slide. Okay, so the randomized controlled trial focuses on the same surgeries that we have focused on from the very beginning. So from Nick's paper, looking at the pre-op testing rates for lumpectomy, hernia repair, and laparoscopic cholecystectomy. Again, these are all outpatient elective operations. Admittedly, when somebody comes in with an incarcerated hernia in the ER, that's a whole different animal. Of course, you should get a CBC in that situation. When somebody comes in with acute cholecystitis, of course, you should get a CBC and a CMP in that situation. That's not what we're talking about here, right? Here, what we're talking about is elective. I have biliary colic. I have a hernia that I've had for 10 years, and it's electively scheduled, and it's going to be an outpatient operation, and I'm a low-risk patient. What tests do I need? And for many patients, the answer to that is nothing. It's like Michael Corleone in The Godfather 2, right? He said, here's my offer. Nothing. Absolutely nothing. I mean, that should be it. That should be the baseline here. And I think what we're trying to do is get people to change their mindset from let me order all of these tests except when I don't want to let me order none of these tests except when I need to, right? It's just changing that default. I saw a question in the chat about, how do we enact this over a system? And I think that's exactly how you do it. It's about getting the leaders in anesthesia and in surgery, in the relevant surgical disciplines on board to say, look, our new default is going to be you don't order testing for these procedures when they're being done on an outpatient basis in an ASA class 1 or class 2 patient. We could even argue about class 3, whether you really need these tests in them. But, for purposes of keeping it in lockstep agreement with a huge body of literature, as Jennifer mentioned as well, that shows that ordering tests in these patients does not improve the safety of the surgical procedure. It does not reduce complications. It doesn't reduce any of the other things that we try to avoid in this setting, like admissions or ED visits and that sort of thing. So there's just really no good reason to be doing it on a routine basis. Now, if you were able to establish this new kind of normal of we don't order tests in these patients, and you've got somebody going rogue who decides in their patients they want to order them anyway, or they play a little bit fast and loose with the guidelines and they kind of always seem to find a reason to order a test, don't worry about it. You're still going to have such a dramatic decrease in your testing rates just by setting that as the new default, that even if everybody doesn't jump on board wholeheartedly from the get-go, I guarantee you'll see a big change. And eventually, they will start to get it as well, because somebody's going to ask them, how come you order all these tests and none of your colleagues don't? And I don't notice any difference in the outcome. And the evidence shows that there's no difference in the outcome. They'll come on board. But, you don't necessarily have to convince every single person right off the bat. I think the key thing is to get your leaders in all of these disciplines on board to say, our default is going to be this, that for this class of patient undergoing this type of operation, we don't order testing, right? Surgeons are terrified that their cases will be delayed or canceled, right? So most surgeons just want to know that anesthesia is on board, right? The anesthesiologists obviously don't want an adverse outcome that, is going to come back to bite them. But again, demonstrating that the evidence, again, suggests for most of these patients that these tests are not indicated, in our experience, has really convinced a lot of the anesthesiologists. I mean, the truth is that most of the anesthesiologists are well aware of this evidence. It's just, again, become such a matter of habit, right? And nobody's really asked them to stop ordering these tests. We were at an institution a couple of weeks ago doing a site visit for their project, and they told us about the huge number of tests that they end up ordering the morning of surgery because the pre-op testing that they think they need hasn't been done. And so now the lab's getting a whole rush of stat CBCs the morning of surgery. Imagine how happy your lab would be if they didn't have to deal with that. If everybody could just agree, we can proceed on this case safely without getting that stat CBC first thing in the morning. So I think there's benefits, beyond the ones that I've talked about. There's real benefits for the hospital and the system in terms of improving the efficiency, improving the throughput, decreasing canceled cases and unused OR time, decreasing delays, and again, as a result, making less efficient use of your OR time. Not to mention, what patient is going to be upset that they don't have to get a needle stick the morning of surgery to get labs before they can go back to the OR. So I think everybody really wins here if we do this in the right way. There's overall testing rates to qualify for this study of greater than 40%. We're looking at kind of, relaxing that. But for right now, I think we're going to stick with that because in order to show a change, you kind of need to have a testing rate that's high enough. That doesn't mean that if you're less than 40%, that you can't still get even lower. And we're, happy to share all of this information. It's all on the website and, there's no secrets here. So we're happy to provide that support. We just can't enroll you in the trial if you're already below 40%. For better or for worse, there's plenty of hospitals in this state that are above 40%. So, lots of people still qualify. You can go to the next slide here, Emily.
Got some more.
Yeah.
I think in
So,
the interest of time, we are going to drop the link
yes,
for
let's
the
do that.
post
And
Workgroup
I don't think we
survey.
need to go over this slide. And
Okay.
this is kind of inside baseball on how we're doing the study,
It's-
which, probably doesn't matter to most people in the group. I think the message I want to leave you with is this. Especially if you are enrolled in the MSQC or the MVC P for P. I think enrolling in this trial should be a no-brainer for your institution. And, you've got the link in the chat. Feel free to email me directly. Emily, if you don't mind, just put that in the chat so I'm not trying to type and talk. Email me directly. And the reason I say that is because this type of trial isn't what you might think of as a typical randomized trial where either you get the intervention or you don't. Everybody gets the intervention. So everybody gets the package of support and materials and help and coaching and all of that stuff. All that varies is when along the pathway you get it. So some people will get randomized to get it earlier, others will be randomized to get it later. But at the end of the day, if you participate, you're going to get the help. So my approach would be, if you're in the P for P, why wouldn't you want some free help to help you perform better in the P for P, right? But, I'm happy to, talk one-on-one with anyone who has questions or has concerns about whether this is right for them. And again, even if you don't qualify, based on that 40% cutoff, we're happy to share the materials because we think everybody could benefit from this, and we don't want to hold back on that. And just to be clear, you don't have to be in the P for P to participate in the trial. As long as you meet that 40% threshold, you're welcome to participate in the trial. I just think it's of special benefit for those in the P for P because you're actually getting money at the end of the year if you do well on this thing. So I would really encourage you all to, look into this and see if it might be right for your institution. And we're happy to make a more in-depth presentation to you, kind of tailored to your particular institution, show you some of your data, show you some of what we've learned. We have materials that could be sent to PCPs to convince them that they don't need to be ordering this. I heard a question earlier about kind of collating the data and the information in one place, and that was on some of the slides that Jennifer showed as well. We've done all that work for you. It's ready for you to put your logo on it. So, this comes from McLaren, this comes from Henry Ford, and you can send this out to your referring docs or to your anesthesiologist or to your surgeons and say, this is the way we're going to do things from here on out. Here's the data, here's the evidence, and we are happy to walk with you lockstep to help support you in any way we can. So thanks for your attention. Thanks for the time. I know we're out of time. I'm happy to stick around to take any questions, but I understand some may have to go.
Thanks, Hari.
Thank you.
Yeah, so just wanted to open it up if there were any questions while Jennifer and Hari are still on the call with us. If anyone had a question they'd like to unmute for, please feel free. And give you a minute or two to do that. Otherwise, we will include contact information for Jennifer and Hari in the follow-up email, so you can connect with them directly if you have any additional follow-up questions, especially if you need to go. We know it's past 1 o'clock. For those of you that are still here, I just briefly wanted to note that kind of in relation to what Hari was mentioning, there are lots of opportunities to kind of synergize right sizes efforts with things that you may already be engaging with MVC that can kind of help you accrue those P4P engagement points if you're kind of looking for another kind of connecting point to becoming involved with right size. There's a lot of opportunities that would gain you P4P engagement points for MVC that would also benefit engagement with the right size program. And then it looks like we still have some people with us, so I will just briefly go through a couple of reminders of upcoming events. We do have another April work group this month that's going to be a health in action covering one of our most recent MVC push reports. I will actually be walking you guys through our recent process measures push report and connecting that to MVC's data registry. There will be a component of that that will be preoperative testing related as well as cardiac rehab. So if those are areas of interest to you, that might be a health in action work group to attend. Additionally, we have our first 2025 virtual networking event coming up on April 16th. If you have not registered for that and are interested in talking a little bit more about sepsis follow-up, please join us. The registration link will be included in the slides in the follow-up email. All of you should likely have also received a direct email about that event as well. And then last but not least, our MVC Spring Collaborative meeting is coming up a little too quickly here on May 9th. So if you are interested in joining us in Midland at the H Hotel to talk even more about value-based healthcare, we would love to have you join us for a day of poster presentations, roundtable discussions, and podium presentations. And we are always looking for presenters. So if what Jennifer did today for us and Hari as well, thank you again, sounds interesting. Feel free to drop us a presentation proposal form. Once again, that link will be included in the follow-up email. Thank you again for everyone who is in attendance today and to Jennifer and Hari for presenting. We know this was a long one, but thanks for hanging with us. Have a nice day.
Thank you. Thank you all. Thanks, Emily, as usual, for everything. Appreciate you.
Thanks, Kelly.
Have a good one.
Bye-bye.